Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Hello, I'm Dr. Ira Nash. Welcome to Well Said. Today, we'll be discussing multiple sclerosis, a complex and potentially debilitating neurological condition. Here to explain the condition and provide up-to-date information about how to recognize and treat it is my colleague, Dr. Natasha Hameed. Dr. Hameed is a neurologist at Northwell Health, specializing in the care of patients with multiple sclerosis. Natasha, welcome to Well Said.
Thank you for having me.
So first, how have you been doing?
I've been doing well. Thank you for asking.
So let's start at the beginning. I'd like you to explain in basic terms what multiple sclerosis is.
So multiple sclerosis is an autoimmune inflammatory disorder of the brain and spinal cord. And just so that we understand what an autoimmune disease is, it is a disease where an individual's own immune system, which is our body's natural defense system, the soldiers of our body that protect us from any foreign invaders like infection, it makes mistakes. And it inappropriately recognizes our own body as foreign, and it leads to what we call immune attacks. When, let's say, for example, when this immune attack is against the joints of our body, it causes rheumatoid arthritis. If the attack is against our skin, it causes psoriasis. And in MS, this immune attack, it's against our brain and our spinal cord.
Wow. Okay. So that sounds like a pretty serious state of affairs. How prevalent is multiple sclerosis?
According to the National MS Society, and this is data from 2019 and 2020, it was estimated that more than 2.8 million people are living with MS worldwide, and close to 1 million people in the United States are actually affected by MS. The incidence is actually greater in women compared to men, so women have a 3 times greater risk of developing MS compared to men. And over the years, we have definitely seen a rise in overall cases of MS, both worldwide and within the United States. And there are several factors that could possibly contribute to this increase in, cases of MS that we're noting. And for example, there is an increased survival rate for patients with the better health care that we have in place. There's also, we're improving the ways we diagnose MS. So we're possibly, diagnosing MS earlier on, the ways we're reporting MS. And of course, there's also the establishment of clinical registries, which helps gather information about MS cases.
So do you think that the apparent rise in the number of people with MS is just a matter of better case finding and better reporting, or do you think that, in fact, more and more people are getting it?
Both, actually. I do think there is an increasing incidence overall, but of course the diagnosing, the reporting methods that we're using have also advanced. So that, in addition to, of course, the increasing incidence, in my opinion, yes.
Yeah. So you mentioned that women are much more likely than men to develop MS. Is that understood why that's the case?
So we see that a lot with other autoimmune diseases in general. Women seem to be at a higher risk at developing MS, developing autoimmune conditions. It may be just, their, genetic makeup or, a component of hormones being involved too. But the risk in MS is a 3-to-1 ratio. So, in the past, they thought it was like a 2-to-1 ratio. But we're also seeing an increased incidence of that females are, becoming more likely to, be at risk for developing MS compared to men in general.
Is there much known about the other risk factors other than being female? Who is most at risk for developing MS?
So the risk, when we talk about risk of MS, there's usually a combination of both genetic and environmental factors that play a role. So it's not one of your typical inherited diseases, so where a disease is passed down from generation to generation, but rather, certain genetic variations could put one at risk of developing MS. So other common risk factors that we think about is one big one is vitamin D deficiency. So especially those who live further away from the equator, we expect them to be at a higher risk for developing MS, and possibly, related to decreased sun exposure or decreased natural vitamin D exposure. Other risks other than the vitamin D and lately of interest as well, and we have some convincing evidence to also suggest the involvement of a prior viral infection as being a trigger for developing MS, and the one that's of particular interest is the EBV viral infection, which causes infectious mononucleosis, what we commonly known as mono. And lastly, cigarette smoking can also be an independent risk factor. So those with a history of cigarette smoking not only may be at an increased risk of MS, but also cause poor disease prognosis too in those who are active smokers.
That's really interesting. Let me pursue a couple of those things that you raised. And the first is vitamin D. So you said that people with lower vitamin D are more likely to get MS. Did I get that right?
Correct.
Vitamin D deficiency or a low vitamin D level on a blood test is a pretty common laboratory abnormality. How strong a risk factor is that? Because I'm sure many of our listeners have been told by their doctor that they have a low vitamin D level. Maybe they should take vitamin D, maybe they shouldn't. That's a little bit controversial. But is this something that everyone with a low vitamin D should be worried about?
So no, not necessarily, like I kind of highlighted earlier on. So it's usually a combination of genetic and environmental factors. So just, having a low vitamin D level or having had an Epstein-Barr virus infection in the past or being a smoker does not put you at a risk for developing MS. There's a combination of different factors that play a role, and we don't really clearly understand how these risk factors necessarily cause MS, so that's kind of still a mystery out there. So we've not really identified a single cause for MS. So, I wouldn't say a low vitamin D level itself would, indicate someone's going to develop MS in the future.
Yeah, I'm glad you mentioned the same thing around the EBV or Epstein-Barr virus, because that also is a super common viral infection. And I didn't want to leave people with the impression that everybody who had mononucleosis is destined to go on to MS. You're not saying that at all, right?
No, not at all.
Okay. Is there any known association with disturbances of the microbiome? We've been learning more and more about the effect of the microbes in our gut on our brains, and we've actually done a couple of shows about that on Well Said, and I wonder if there's an association that's come up between the microbiome and the gut and the risk of MS.
Interesting you brought that up. So there have been studies from what I know looking into that. Again, I don't think we have solid information or evidence to say that that's one of the leading causes for MS. But the gut microbes do play a role with our overall immune system. So, poor diet can be associated with poor outcomes in MS. So there's probably some relation there. As far as, like you mentioned, gut microbes affecting the immunity, which then leads to a dysfunctional, immune attack like MS. So, it's definitely an interesting topic, and I guess we just need further research to provide more strong evidence there.
Okay. So you mentioned that the sort of underlying basis of the disease is this immune attack on the brain. Could you say a little bit more about that? Do we understand what the underlying biology of that is?
Mm-hmm. So today, we don't clearly understand what triggers the onset of MS. We do believe, like I mentioned, the risk factors that I highlighted on earlier could play a role, but ultimately a single cause is yet to be identified. But we do understand, so we don't know what the cause is, but we know exactly what happens. What happens in MS is, one, we have the dysfunctional immune system, which attacks the brain and spinal cord, and it targets or damages or injures a structure in the brain that's called myelin. So myelin is the protective coating around our nerves, or the blanket around the nerves, which allow, signals to cross from point A to point B, from our brain to spinal cord and back really efficiently. And when MS causes an attack on this myelin structure, it disrupts the entire flow of signals. And when that happens, depending upon where it happens in the brain or where it happens in the spinal cord, it can manifest as clinical, like physical symptoms. Like it could be vision loss in one eye, it could be weakness of your arm, legs, or affect your gait and trouble walking. All of that could occur following an immune attack.
If I get you straight here, the immune attack targets kind of the insulation on the wiring in the brain, and then depending on where the breaks in that insulation occur, that's going to dictate what a patient experiences and what you as a clinician will see as an abnormality in that patient's clinical status. Is that about right?
Absolutely, that's correct.
So are there any screening tests that can be done to identify those people who might be at risk for this?
Really no indication or recommendation to screen patients with MS unless they develop what sounds like a typical MS symptom. So, just having a family member with MS, or having low vitamin D levels, or the Epstein-Barr virus infection does not warrant the need to pursue a workup for MS. And I would generally not recommend that, especially since unnecessary testing could lead to a lot of confusing results. So I don't necessarily recommend screening patients for MS.
Let's get back to the diagnosis then. So you mentioned that the effects or the symptoms could vary widely depending where in the brain or spinal cord the myelin disruption occurs. So that means it sounds to me like it's tough to make this diagnosis then, right? Because it can present in lots of different ways. Are there specific tests, blood tests or imaging or other things that you do that allow you to be certain in your diagnosis?
You rightfully said that, MS can present in many different ways, and many different symptoms, which can mimic other conditions, not only in neurology, but in, different medical diagnoses as well. So ultimately the diagnosis of MS is made through, thorough clinical history, kind of getting a sense of what kind of neurological symptoms they've had in the past, at what point in time they had those symptoms, a thorough physical exam. So not only the general physical exam, it also includes our neurological exam. So we're looking for signs of, weakness, or signs of, like a vision loss in a patient. And of course, one of the most important tests we do is a brain MRI, in which we're looking for what we call white matter lesions, which are basically spots in the brain or spots in the spinal cord, which indicate that there's been some kind of inflammation and led to a scar in these areas of our central nervous system, our brain and spinal cord. And in certain cases, but not all, a spinal tap may be needed as well, just for further clarification of diagnosis.
One of the other things that I've heard about MS is that the time course of symptoms can be highly variable, and that some people have sort of a rapid and significant decline. Other people have sort of waxing and waning symptoms. Can you speak to that a little bit?
So the MS disease course is very unpredictable. I mean, you can't compare two MS patients together, even if it's a first-degree relative of yours with MS, or even if it's your twin with MS. You can't compare MS disease courses, and that's what actually makes it hard to prognosticate with great certainty, especially early on. When you diagnose patients, there's several factors that can play a role in, the prognostication. And, there are a few prognostic factors which have been associated with less favorable outcomes, and that would include like male gender, being diagnosed at a, a late onset, which, there's no particular cutoff there, but possibly older than 50. More motor symptoms at the onset, so someone presenting with their first MS clinical attack with weakness or trouble walking, as opposed to someone presenting with more sensory symptoms like numbness or vision loss in one eye. And of course, if they have poor recovery of their symptoms after their initial attack, have frequent bouts of relapses within the first 1 to 2 years, and of course, the greater the disease burden that we've seen on the brain and the spinal cord as well, that can also mean a less favorable outcome in most cases.
I'm also thinking that the same challenge that you as a physician face in making a diagnosis is the challenge that patients have when they get a new symptom to determine whether it's something they should be concerned about or seek medical attention to evaluate, because, again, this can present in so many different ways. So what would you say to our listening public about what kinds of symptoms they should be seeking medical attention to evaluate or concerned enough to ask their doctor about?
Sure. So there can always be an overlap in symptom presentation. Just for example, like a patient with a history of diabetes, they can have what's called diabetic neuropathy and, experience numbness, tingling in their feet, which is a very common symptom in MS as well. But, just to put it out there, if there's any symptom that you're concerned about, whether it be, a vision symptom or weakness, numbness, tingling sensations, always address it with your primary care doctor, and, they'll refer you to a neurologist and so forth. But anything that anyone's concerned about, always bring it up to their doctor, just so that, we can evaluate and see what needs to be done further.
And you mentioned one of the things that you use to prognosticate, to kind of determine who is likely to do better or worse, is the time course of a particular kind of symptom. Is it typically the case that a particular symptom may get better, or once you have numbness from MS, that's kind of a permanent deficit that's going to be with you forever? Yeah,
so the natural MS disease course, there are 80% of cases, they usually develop what's called a relapsing form of MS. So they develop a symptom, and usually that symptom improves. And it could take anywhere from a few weeks to, a couple of months, up to 6 months for the symptoms to get better. And majority of patients do, get full recovery of symptoms. But then again, there are a small percentage of patients, depending upon what your disease, courses, that may be left with some residual deficits as well.
I see. So what's your general approach for the treatment of patients with MS? So you've seen somebody who has some of these symptoms, you do your thorough evaluation that you talked about, you do the imaging studies, and you make a diagnosis. What's in store for the patient next?
There are actually a lot of treatments that we have in our bucket list these days. So there are close to 20 FDA-approved treatment options for MS. And, the first treatment was actually approved less than 30 years ago, so there's definitely been a lot of advances in the field of MS there. And when we talk about drugs, and I usually try to, separate my visits as far as diagnosing MS and kind of going over, the details of MS, and then have them come back to just discuss treatment, because it can be a whole lot there to talk about. So the treatments of MS, there are several different treatments, like I just mentioned, and they differ in a few ways. One is their mechanism of action, how they, act in the body. Their side effect profiles can vary, and then, of course, their route of administration. So we have medications that are given through self-administered injections. We have oral medications, pills that patients can take once a day or twice a day. And then we have our infusion treatments where patients come to an infusion center and get an IV line and get medications through the infusion. But all in all, they function by modulating or suppressing the immune system in a way to not only prevent us from developing immune attacks, but also to slow the disease progression as well.
It sounds like patients have reason for hope that these medications are effective in halting the progression of disease. Is that correct?
Correct. So another thing that does slightly differ amongst the treatments is their efficacy profile too. So there are medications which, fall under the mild to moderate efficacy, and then we have our very highly effective treatments as well. So there's a lot of hope. I mean, with all the advances that's occurred in the last few years with MS, and the development of new highly effective treatments, which we've seen, be able to protect MS in so many ways, and really slow their disease course. So it's been great, with all the new treatments that we have.
Yeah, so take us a little bit into the future. What are some of the latest research areas that might hold out even greater promise for patients with this illness?
So there are several studies focusing on different aspects of MS. Of particular interest these days are studies looking into therapies for the progressive types of MS, primarily the primary progressive form of MS. So currently all the FDA-approved treatments that we have for MS have been, in the clinical trials, have been studied for the relapsing types of MS. But as far as for primary progressive MS, we do need, a little more, trials and studies which are currently taking place right now. There are also studies looking into therapies to help repair nerve damage, which we call remyelinating therapies, which would be a great addition for the future to add on to our preventative therapies. So like I mentioned earlier, the current treatments, they focus more on prevention, not really repairing the damage that's already been done. So, being hopeful that when we do get these remyelinating repair therapies, that it can not only are we preventing MS, but we're also repairing the damage that's already been done. And furthermore, there are also biomarkers that are being developed to help monitor the disease activity, to monitor our response to drugs, and also help prognosticate disease course in people with MS as well. So a lot to look forward to.
Yeah, that sounds exciting. So if our listeners are interested in learning more about the current and future state of MS, are there sources that you can recommend for them?
So my go-to, and what I usually recommend to my patients as well, is the National MS Society website, which is the www.nationalmssociety.org. It's a great resource for anyone who would like to learn basic and reliable information on MS, and a lot of what we covered today could actually be found on that website as well.
Terrific. All right. Well, thank you so much.
Thank you for having me again.
My guest today has been Dr. Natasha Hameed. She is a neurologist at Northwell Health, specializing in the care of patients with multiple sclerosis. For more information about this program and to find past episodes, please visit medicine.hofstra.edu/wellsaid. You can also subscribe to our free podcast wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.